Okay, so now we're going to talk through getting out of bed with a knee or an anterior hip. They're kind of similar. There's nothing unique about each of them. So with an anterior hip, there really truly are no precautions typically. Dr. Nelson Friend is a caveat. But the only thing you want to avoid is bringing that surgical leg really far into extension. So nothing we're doing with bed mobility is going to hurt that hip. And with a knee, there aren't any really restrictions as well, aside from we don't want to keep that knee bent when you're in bed. So right now the foot of the bed is up a little bit. So I always want to make sure that's down and then locking it out on the bottom of the bed so that the patient can't be up. If they're stuck in this kind of flex position for an extended period of time, that knee isn't going to want to straighten out. So we always want that knee flat while they're in bed. So 2 techniques to get out of bed this way. If a patient has good upper body strength, I typically recommend using the long sitting technique like a posterior hip. So Karen's going to use those arms, kind of get up onto her elbows. Beautiful. From here, it can help again to flatten out that bed so she's not fighting the bed a little bit. And then she's just going to walk that surgical leg out to the side. She is moving beautifully. If she wasn't, we can always help bring that leg over. And then with the knee, sometimes it's helpful to kind of keep it out a little bit. We encourage patients to bend their knee as she's doing. It's kind of pain tolerance, especially in acute care when it's day of surgery, day after, 2 day after. But if they can bend it, that's great. The hips, no restrictions at all. Getting back into bed is just the opposite. If she has, like I said, good shoulders, good upper body strength, she's gonna kind of just scoot that butt back again, pivot on those hips, and lay back down. For patients that have either a larger body habitus, we'll see it with like the older gentlemen, typically with more of the belly, or who have bad shoulders or weak shoulders, we can also practice more of like a log roll like we would for a spine. So Karen can bend up this leg a little bit. She's going to reach across over for that railing and then kind of come on and sit up that way. We're not as worried about the flexing, the adducting, or the rotation with the posterior hip or a knee. It's more of their pain tolerance. Can I have you lay back down for just a minute? Just another tip and trick while we're chatting about it. For patients that are having a hard time moving that leg, we can always take a gait belt and tuck it over or wrap it around their foot. And then when Karen comes to sit up here, she can use her arms to help bring that leg over with the gait belt. Same thing for getting that leg back. Same thing for getting that leg back into bed. She can kind of pivot into bed a little bit, use that strap to help lift that leg up. We encourage the patient to do as much as they can because 1, we're not going home with them, and 2, we don't want to hurt ourselves lifting legs up into bed.
And then can you just teach the ramp style?
Oh yeah.
The pillows.
Yep. So positioning at the end of a knee. If they're in the chair, we encourage them to have their knee bent, right? We want it to bend as well as straighten. Like just kick Karen's head up just a touch here. We want to avoid keeping that knee bent at all, right? So now the foot went out again, so let me just lower that back down. So when we elevate, we like to create a ramp style of pillows. So what that means, I'm going to show you what not to do first. This is what we don't want to do. Lift that leg. Is tuck a pillow directly underneath that knee because now she's flexed, right? This probably feels great because it's typically less painful here, but that knee is now starting to get really comfortable bent, and that's not what we want. So we like to do kind of a ramp. So I sometimes will do one here, one here, one here, and then you kind of reassess to keep that knee nice and straight. And it doesn't need to be, perfectly straight, but we want to avoid any bend in that knee if at all possible.